Gives me pleasure to introduce you to Dr. Timothy Hughes. He is an assistant professor in the Department of Internal Medicine at Wake Forest School of Medicine and the Wake Forest Alzheimer's Disease Core Center. His research focuses on untangling the complex relationships between vascular and metabolic disorder and how they relate brain abnormalities commonly seen in aging, Alzheimer's disease, and other dementias. Dr. Hughes.
Wonderful. Thank you all for inviting me here today to speak to you about the exciting world of Alzheimer's research, where we've been, where we are now, and where we're going in the future. So I would like to start off with talking to you a little bit about the past, the historical approaches that we've taken to treating Alzheimer's disease. And that has really been unfruitful, to say the least. We'll talk a little bit about why that is. And what that has done is it's caused a paradigm shift for us. Yes? Yeah. Yes. It's actually not as clear-cut as you would think. I'll be talking great question. We got to start on the same page. Is it just Alzheimer's disease? One of the paradigm shifts I'm talking about today is that the idea of pure Alzheimer's disease is actually pretty rare. Less than 25% of all the cases with Alzheimer's disease have a pure form of the disease. So that's going to lead into where we're talking about with these paradigm shifts and moving forward. Yes, absolutely. So don't worry, I'm not going to talk about plaques and tangles the entire time of this talk. And then we'll wrap up by talking about some of the early treatment strategies and potential prevention strategies that are now being tested in clinical trials. So let's first talk about what Dr. Alzheimer saw. This was in 1906. He was describing his first patient that he wrote down about Alzheimer's disease, and he described plaques and tangles in the brain. But he also described inflammation in the brain. And that has actually been lost over the past 100 years. In the past 100 years, we still don't, since that 100 years has passed, we still do not understand why we get plaques and tangles in our brain. And that's kind of remarkable when you think about it. We still don't know why we make amyloid that makes plaques and why tau turns into tangles. So here's what I'm talking about. I have to, if I'm going to talk about Alzheimer's, I have to show this, right? This is plaques and tangles in the brain. Just about everybody in this room, I'm sure, has heard of these. They are the hallmark features of Alzheimer's disease. Don't get me wrong. If you don't have these features, you don't have the disease. Okay? That is the diagnosis of it. It has to have at least one of these two features. So that plaques in the brain were thought to be a causal agent that caused the disease. What we realize now is that these plaques are actually more like a scar that is found in the brain to show that there's been a lesion or a response by the brain to deal with something. What seems to be more closely related to the cognitive changes that we see in older adults with Alzheimer's disease are these neurofibrillary tangles. These tangles have been sort of second fiddle to amyloid over the years and drug development. There are treatments now that are coming out that are targeting specifically these tangles in the brain, and we'll talk about a few of those. They're often considered tombstones of where neurons were. They're inside the neuron, so you can actually see at the bottom right one with neurofibrillary tangles, you can actually see where the neuron was. It's now filled with these neurofibrillary tangles. So we have to start with what are the treatments right now. The current treatments for Alzheimer's disease and other forms of dementia are symptomatic. They do nothing to change the underlying pathology or trajectory that an individual is on in their disease course. At best, they can hope to improve symptoms a year and a half at best, and then individuals will continue to decline because it's doing nothing to change their course. Because of this, and because of our wonderful baby boomer generation, which I'm sure there are some of you in the room, the number of cases of Alzheimer's disease are expected to triple in the coming decades, unless we find a way and new approaches to combat the disease and to either treat more effectively, cure, or prevent the disease. I'm going to let you in on a little something that we don't talk about much. The incidence, the number of cases per year of Alzheimer's disease is actually going down. It's been going down for a decade. So why is this a big problem? Well, it's these numbers here. We have more people at risk now for Alzheimer's disease than we've ever had. There are more people in the baby boomer generation who are now becoming at risk. But your individual risk has actually gone down a little bit. So we're actually doing something right, and we have no idea what we're doing yet. So let's talk about how the lack of treatments and a lack of cure has caused paradigm shifts in the disease. Here's what I'm here to talk to you about. Alzheimer's disease is more than just plaques and tangles. Pure plaques and tangles, as I said, account for about 25% of all the cases of Alzheimer's disease. What about the rest of the individuals? We're going to talk about that. The clinical diagnosis of Alzheimer's disease is wrong sometimes because it's based on signs and symptoms of the disease. That may not be indicative of the underlying pathology that's in the brain. So we're going to talk about how we can reconcile these differences. And research strategies now focus specifically on evidence of pathology in the brain. And there is hope. There is hope. And the reason for that is because we can see the pathology in the brain, and we now know that this takes years and decades to form before someone even shows cognitive symptoms. What does that mean? That means we have a big window. If we can see the signs of the disease far before the symptoms, we can do something to change someone's course. The bad news has been the focus on amyloid and amyloid-based therapies. There have been a lot of recent failures. Actually, there hasn't been a new drug on the market, unless it's been repurposed, for Alzheimer's disease in the past 15 years. That, paired with the fact that the investment by pharmaceutical companies has been massive to try to find new treatments, but they've been mostly focused on amyloid and been focused on this process where an individual, amyloid is made as this amyloid precursor protein. It's cleaved into the protein form, and then that form starts to misfold and actually starts to build up in the brain. That turns into fibrils and then eventually plaques. Well, the idea has been simple. Let's remove them. Let's take away all the soluble amyloid so that no more plaques form. The first trials failed a few years ago, and the thought was, we're starting too late. We can't do this in people who have moderate disease. Too much damage is already done. So we need to move earlier in the disease course. And just recently, there's been another major failure of anti-amyloid therapies. These are antibodies that actually go in and remove these amyloid proteins from the brain. But they're not doing anything to change the course of the disease. So that makes us ask ourselves, is it all amyloid? Is amyloid really the thing that drives what we see in Alzheimer's disease? So thus far, the newest sort of next-gen treatments of Alzheimer's disease, there's been no positive findings. But there's still hope, and I'll tell you why. It may be back to, you may have heard this Sanskrit fable about men who cannot see what they're trying to feel here. In this case, it was blind men who were trying to feel something and then describe what it is. And no matter which part of the elephant, which they couldn't see, they described, they focused on, well, it's got to be, this has to be the most important part because this is what I'm touching. And that's where we've been with amyloid for a while. So, Alzheimer's disease is dementia when it impairs someone's ability to function on their own. That's the simple definition. Not all dementia is Alzheimer's disease. 85% is thought to be Alzheimer's disease. As I mentioned before, only 25% of that 85% is pure. So what's going on there? This diagnosis has traditionally been made by a clinical examination and cognitive testing. You rule out other forms of dementia, like Parkinson's dementia or Lewy body dementia based on signs of the disease, and then you do cognitive testing to find out what aspect is impaired. Is it memory or is it another part of our thinking abilities? But traditionally, this has had no information about actual pathology in the brain, and therefore, in the past, the disease could only be diagnosed at autopsy. And that doesn't help anyone, right? So, because of that, those people who are diagnosed with probable Alzheimer's disease, which is the best you can do based on cognitive testing and neuropsych evaluations, 30% of them actually don't have Alzheimer's disease, because when we image everyone who's been diagnosed in a particular group, 30% of them don't have amyloid in their brain. So what do they have? Have we actually been treating the wrong disease in a large portion of our people we consider to have Alzheimer's disease? So this is a very busy picture, and I apologize for that, but here's what you take from it. In the yellow, we've got Alzheimer's disease pathology. And then in the red or pinkish color, we have non-Alzheimer's disease pathology changes, and there's an overlap. And we're taking into account amyloid and tau, and then brain shrinkage called neurodegeneration and cognitive impairment. And the overlap of these is actually smaller than the bigger problem. But looking at the pathology tells you what type of disease this person has, even though they look like they might have Alzheimer's disease. Amyloid and tau are just two forms of protein that actually build up in the brain. Okay? And there's a lot of overlap between this protein misfolding and its buildup in different conditions. Parkinson's disease and Lewy bodies tend to be high in alpha-synuclein. Lewy body and Alzheimer's disease have a lot of amyloid. Tau could be Alzheimer's disease, but it could also be CTE, which you see the football players get. ALS has another form of protein. What I'm trying to show you here is that there's actually a lot going on. So if you stain for just one of these at autopsy to see if it's there in the brain, you'll miss the others, because these are all problems with protein misfolding and protein buildup that can help you characterize what's actually going on in the brain. So what about that other 75%? The other 75% of people with Alzheimer's disease don't have pure disease. They actually have a mixed pathology. And the most common form is Alzheimer's pathology plus vascular disease in the brain. These are two age-related phenomena in the brain that are thought to be independent of each other, but when you add them together, they're worse than having one alone. Okay? The next most common is Lewy body, and then vascular and Lewy body, and then vascular and Lewy body together. So what impact does this make? Even neuropathologists who are so interested in what protein is misfolded now are starting to understand that it doesn't necessarily matter what type of protein or damage is there in the brain, but just how much is there. So at the bottom line here, we have somebody who has pure Alzheimer's disease without any other changes in the brain. And then as you add these changes, in this case, it's small infarcts or strokes in the brain, it increases the risk for having dementia with each one of these that you add on top of the pathology that's already there. This has caused a big paradigm shift for us in the fact that we can now look for this pathology in the brain. And when we look at the spinal fluid, or when we image the brain, we actually see that there are changes in the spinal fluid and in the structure of the brain that are occurring years and decades prior to someone developing even mild cognitive impairment or Alzheimer's disease. So this gives us a large window to visualize and treat and change someone's path. And how do we do this? Well, it's the exciting world of PET imaging. PET imaging's been brought out. MRI was everything for the longest time. But the power that PET imaging gives us is it allows us to inject a tracer that binds to a specific protein. In the top, it's showing where sugar is used in the brain through glucose. And that's one of the earliest signs of Alzheimer's disease or a neurodegenerative disorder, is that the brain stops metabolizing sugar well. The next one down is PID-PET and other forms that actually bind to plaques in the brain. And over the past 15 years, since this has been developed, we've been able to use this in research to see individuals who actually have pathology in their brain and they're still alive. And what that's shown us is that this is actually common in aging. People get plaques in their brain, but they may never show symptoms. So maybe it's not all amyloid. The last one is the most exciting for us, and we're integrating this into some of our research studies now, and we're able to visualize how much tau is deposited in someone's neurons. The brighter that shows up on these images, the more the deposition is. The location where it is shows us what stage of the disease someone's at. So to summarize these paradigm shifts, is that they've allowed us to move towards prevention of the disease because we can see it. We can now focus on this preclinical phase to change someone's trajectory, and maybe they won't develop dementia, and then we won't have to treat it. There's a question of how early do we start? I'm going to talk to you about some of the studies that are ongoing right now for dementia prevention, and you'll be surprised that the vast majority of you are actually eligible for studies like this. We're not looking for the person you know has dementia. We're looking for people who are doing just fine, who are maybe starting to feel as if their memory and thinking abilities are not what they were 5 years ago. Okay? So that's also brought us back to re-examining the role of risk factors and lifestyle. And some of the strongest evidence that we can prevent dementia is actually coming out of lifestyle interventions. Oh no, he's going to tell us about diet and exercise, isn't he? I'm sorry, I am. So, is dementia too late? When we're talking about that continuum, going from normal to dementia, there's actually an area in the middle that's very interesting for us, and it's called mild cognitive impairment. If you haven't heard of this, it's essentially having an impairment that you can see on cognitive testing in some aspect of your thinking and memory function, but you're able to just function fine. You may not feel like everything's going on well, but when you take tests, it's looking like it's like you're falling and slipping below the normal ranges. But there's also this area here that's even more interesting to us. Just feeling as if you're not as sharp as you were on specific tasks. And I'm not talking about just that normal age-related thing of, oh, I can never remember that word that I'm thinking of. I'm not talking about that. I'm not talking about occasionally taking a wrong turn. I'm talking about leaving someplace and saying, wait a minute, where am I and where am I going? Okay? That type of feeling, that subjective complaint that we hear, actually increases the risk for getting dementia. But it doesn't mean that someone will. So here's some of the questions that we assess when we're looking for people in these early treatment studies. Is your memory worse than it was 5 years ago? Is it worse than others your age? Are you or a family member concerned about memory changes? Have you gotten lost in familiar locations in the past year? Have you had more trouble understanding instructions in the past year? These are questions that you can use to help you understand if maybe someone you know, or even yourself, might need to go and find out what's going on. So let's talk about early treatment. What can we do? Well, there was a huge report, two huge reports that just came out. One came out from the National Institutes of Health, and the other came out in the UK, and they're talking about how are we going to prevent dementia and thereby prevent Alzheimer's disease. Here's what it came down to. Here's the best evidence. Not any drugs, unfortunately, for the so much money that's been invested there. Blood pressure control, cognitive training, and physical activity have the best preventative evidence so far. You probably won't be able to see all the things on the left, but the idea of this is there are things that affect us through our life, and we pick up risk factors through our life. Interesting, early in our life, low education is a risk factor for getting dementia later on. Continuing to stay active and educated like you're doing here today actually lowers your risk. When we get into middle age is when the risk factors start picking up. And what we find is that this is when the traditional cardiovascular risk factors become very important for our risk later in life. The two strongest modifiable risk factors for Alzheimer's disease are hypertension and dementia. Hypertension and diabetes. When you work on controlling these two risk factors, you actually work on controlling someone's risk for getting dementia. But the nexus of all of this is exercise, and we'll actually talk about some of the intervention studies that are going on right now. Some of the other untreated medical conditions that increase our risk for getting dementia later in life, don't worry, if you have any of these on the list, it doesn't mean you're going to get dementia. Let me be very clear about that. It just means that the more of these that you have, the higher your risk is of getting dementia. Because as we age, a lot of these become age-related factors as they increase with age. I'll be happy to answer any questions about any of these. So let's talk about what we're doing now. You may not be aware that as of 2016, Wake Forest has the only NIH-funded Alzheimer's center in the state. We're actually only one of two in a 8-state region. There's only 3 in the South, if you don't count Texas. I don't count Florida as the South either, but in that case, there's only 2. Which is really surprising because what I've just told you is that lifestyle risk factors matter and that prevention matters. This is the focus of our center. Well, we're not only in the Bible Belt, we're also we've got a few other belts to our titles. What are they? Stroke belt. Obesity belt. The belt wouldn't fit any longer, so they dropped the belt. That opioid probably belt now too, but the other is diabetes belt. So the fact that we've been underrepresented is kind of a travesty when you think about the fact that the NIH has been supporting Alzheimer's centers and ignoring the South for so long. So here's the structure of what we're doing, and here's how we go after this problem of how to prevent. What we do is we first have to characterize people very well. How are you functioning cognitively? How does your brain look? Do you have any evidence of disease? And then what we do is we find treatment studies and prevention studies that are right for the individual. One of these that might surprise you is that we have a phase 3 clinical trial right now of inhaled insulin. Why in the world would that work? Well, it's worked very well so far in the previous phases of clinical trials. This study is testing the effectiveness of intranasal insulin in the treatment of mild cognitive impairment. And what we find is that when insulin is provided to the brain, directly to the brain through being inhaled, what's that? Remember the part that I was talking about with the imaging? One of the first signs is low glucose utilization in the brain. Well, this actually improves glucose utilization. It's a bit of a pep for the brain. We don't know if it's a long-term solution, but it's actually changing Alzheimer's disease biomarker profiles. So this is in a phase 3 clinical trial right now. Yes? No. It's actually focused on treating people with pre-diabetes or normal glucose levels. One of the things is if people are taking diabetes medications, those might interact with what the treatment's trying to do, or it might compound changes in the body. Yes? Yeah. So the question was, in these studies, are we doing the PET imaging to show that glucose is low, and are we doing cognitive testing? Yes, we do. Mm-hmm. Yes. Yep. Mm-hmm. I'll tell you a little bit about how you can find out more about it at the end. But in general, if you know of someone or you yourself are interested in getting involved in studies like this, you can talk to me, or you can call our number, which is 716-MIND, and find out more about the studies. Okay, remember how I talked about the amyloid therapies that were not showing a lot of effectiveness? Well, we're actually treating people who have no signs of the disease now with anti-amyloid therapy. There's a massive multi-site trial called the A4 study and 2 others called Early and Emerge that are using antibodies to remove soluble amyloid from the brain among people who have signs, i.e., we can see the amyloid in their brain, and actually try to remove it to change their course of disease so that they may never get cognitive symptoms. Now we're talking about diet. There's actually really interesting work come out. Has everyone heard of the Mediterranean diet? It's hard not to hear about it in the news. Well, it's actually also called the MIND diet, forms of it, where several studies have evaluated how this diet, changing to this diet from our traditional Western diet, might improve memory and function. What's great about diets like these is they're actually really high in fat. There's a lot of fat in nuts and fish. And what we're doing now is looking at how it's changing Alzheimer's biomarkers. And we're actually finding that in the cerebrospinal fluid, those Alzheimer biomarker profiles are changing. And so we're actually being able to shift somebody's risk just by diet. So there are a couple large studies that are going on. BEAM has finished, and there's another one starting up soon that's looking at people who have mild cognitive impairment specifically to see if we can change their course and actually prevent them from going on to get dementia. Oh, the one that everyone hates, exercise. There are a couple clinical trials going on right now. Wake Forest is hosting one of these. It's called the EXERT trial. And we're actually testing in a clinical trial dose of exercise so that at the end of this clinical trial, if it's successful, you may go to your doctor and say, I just don't feel that I'm as sharp as I was. Is there anything I can do? And your doctor will ask, are you exercising? And we'll all say, no, we're not exercising like we should be. And because no one is exercising to those levels. And you might actually get a script from your doctor that says, this is what you need to try first. So this study is actually looking at how, not just getting the information, but actually getting a personal trainer to get you to the level that you need to be changes your risk. The last one is very exciting. What if one factor of our lifestyle alone isn't going to be strong enough? What if we need to try to change a lot of different things? So Wake has partnered with Cornerstone and the YMCAs to start a multi-domain intervention study. This has a dietary intervention, a physical activity intervention, cognitive training using computer-based tools, and monitoring and maintenance of metabolic and vascular risk. This is the second generation of a study. The first came in Finland, and you may have heard about it on the news, where they actually showed that people stopped declining as much in their memory and cognitive function when they went on an intervention like this. So there's hope. There's hope that because we can now see and know who's most at risk, that we can actually do something about it. So finally, how do we get Alzheimer's disease? Aging, genetic risk, a buildup of proteins, and lifestyle. We've discussed all of those. Well, how do we stop Alzheimer's disease? We can stop aging, right? Only if you get to choose the age you stop. Don't come to me and tell me you found a cure for aging when I'm 108, because I'm not sure I'm going to want it at that point. Well, we can change our genes. That's probably not reasonable in the near future at all. We can remove the proteins, and there's evidence that that may not help in the later stages of disease, but maybe earlier it can work. And we can work on modifying our lifestyles. So here's the last bit I'd like to leave with you. Here's what we know. Prevention is key. For each of us, if we can increase our physical activity, and I'm not talking about having to necessarily sweat every day, but just decreasing the amount of time that we're sitting. I love doing this, talking to a group of people who are sitting, because we do this when we come together, right? But if we can decrease the amount of time sitting, increase our walking time more, it's actually helpful for the brain. What's good for the body actually is good for the brain. And we're coming to see that. And that may be our strongest prevention tool. Stay engaged and stay connected. You may notice that, and may have heard that people who isolate themselves actually have a higher risk of dementia. And it may be that they're just not using their brain and using and gaining the benefit that we get from social support. Only one individual is getting benefit in this. So, if you want to learn any more about what we're doing, now that North Carolina has a NIH-funded Alzheimer's Center and some of the things that we're doing, you may know individuals who might be good for some of our studies. You can go to Wake/Alzheimer's, or you can just Google Wake and Alzheimer's. The other way is, if you don't know about Be Involved, I highly recommend everybody learn about this. This is our Aging and Alzheimer's Center newsletter, the Vital newsletter that comes out. Does anybody get the Vital in here? Not a single person. It tells you about all the different aging and Alzheimer's prevention studies that we have in the Alzheimer's Center, and it's actually got 4,000 people on the list. So I'm actually surprised not one of you is on it this far. Yep, Vital newsletter, or go to the Stick Center on Aging or Wake Alzheimer's, and you can find out more about those. So I'll be respectful of your time. It's Friday, so if you have any questions, I'll take a couple, and then I can just stick around and talk to you afterwards. Yes, over here, sir.
You were talking about the imaging before the brain. Can they, with the imaging, are they able to determine whether or not a person is dealing with Alzheimer's versus schizophrenia or any other brain issue?
Yeah. Okay, so the question for those who didn't hear it is, with the imaging, can we do a differential diagnosis on Alzheimer's versus another neurologic disorder? Yes and no. They're not clinically used now because they're super expensive. And I should point out that everybody in our studies, because we're NIH funded, they get all of this workup for free. But your doctor wouldn't necessarily want to pay $7,000 for a scan like this. Theoretically, yes, you can tell that there's plaques in the brain indicative of Alzheimer's disease, and they look like they might be getting it, and you can do that. And you can help differentiate out vascular versus Parkinson's and other forms of dementia. Yeah? Yes? Great question. There's really two forms of Alzheimer's disease. There's an early onset form that's driven heavily by genes. Okay, family history plays a huge role in this. And those people can get the disease between the ages of, start showing up in their 30s, 40s, most of the time 50s, and before the age of 65. That's a hard cutoff. An artificial one, but a hard cutoff, because we say all the other forms of Alzheimer's disease, the late onset, happens above the age of 65. The early form of the disease, less than 65, is very rare. 5% of all the cases are early onset. 95% of all of the cases of Alzheimer's disease are the late onset that happen after 65. Yes. And what was the second one? Ginkgo. Oh, okay. Great questions. I can actually, I'll reiterate the questions and then I'll be able to give you reasonable answer, especially for the second one. The question was, does red wine help prevent dementia? And does ginkgo help? We know the answer to the second one. Ginkgo does not help at all. We've done clinical trials on it. The GEM study, we were actually a site here at Wake Forest, and we showed conclusively that taking ginkgo biloba does nothing to help prevent the disease. The second one is red wine, and actually we're not sure if there's additional components in red wine beyond alcohol that would provide benefit. What we do know is that small to moderate amounts of alcohol actually decreases our risk for getting dementia, but we're testing that out now in clinical trials. Everybody wants to be in that study until I tell them this one thing. All right, this is a real trial that's actually starting. It's called the Mach 15 trial. And Wake Forest is a site. But here's what's going to make you not necessarily want to be in it. You don't get to choose which arm of the study you're in. You go in and you get randomized to either you have to drink 1 drink of alcohol a day for 6 years or nothing at all. Hey, wait. Abby's got a couple exceptions. My colleague Abby is here. What are the exceptions? So if you don't have to drink if you're on the flu and in the alcohol arm, and if it's New Year's, how about birthday? We're going to give an exception for birthday too? You get 6 passes? All right. Yeah. And remember, each drink is a pass. So if you have 2, you just... All right, I'll take one more question and then I'll stick around and talk. I don't want to hold you guys up on a Friday. Yes? Okay, great question. So in long-term care, why do we see that you start to see people about at the same place, but some of them it's taken them a very short time and some a very long time? Part of that is when you get to see them. You get to see them at a certain point where their support system can't really manage this any longer. So they come to you at a certain point. Why short versus long? One of the things we're trying to figure out is what causes the disease to progress fast. Some people, it's very fast. There's one genetic risk factor for late onset, ApoE, if you've heard of this before. And this causes the amyloid to develop faster. ApoE. But it's actually a small portion of your whole risk for getting the disease. It just accelerates it when you do. Okay? So we don't know yet why some people go faster. And I think that's because we really don't know what's going on in the brain except for how the brain's functioning. So we don't know what's going on underneath. Hopefully studies like we're doing now and some of the larger studies will show us exactly that. All right, with that, I would like to thank you for your attention and have a wonderful weekend.